All right. Good evening, everybody. I'm Alex Selfand, Education Coordinator for the Salty Dogs, and welcome to another in our Salty Dog webinar series, and in particular, our Emergency Medicine at Sea series. And tonight, I have the pleasure of having again Alex Cullen, who's the Director of GW Maritime Medical Access, talking to us about a gut-wrenching topic for some. Talk about seasickness and GI issues. Just a reminder, please put all your questions in the chat box. We will definitely get to them at the end. If there's anything that we haven't covered that you want to cover relative to this topic, again, put it in there. Because we can also make sure we get to cover those things in the last of those series. And with that, I will say tonight we're coming to you from Virgin Gorda, where the weather is pretty crappy. And thanks to you guys in the southeast, you've been sending it that far away. So please stop, because we've had enough rain. And with that, I will turn it over to Alex. It's all yours.
Thank you so much, Alex. Good evening, guys and girls, and wherever you are. I guess it could be afternoon or evening. I'm psyched to be here again. Sorry, it's me, and we haven't gotten somebody more attractive, but we'll keep going with it. Today we're going to talk about seasickness and GI issues in general, and if we get to the end and y'all have any specific questions, I'd love to be able to answer those for you. Just one quick reminder, we do have another one of these that's going to be on May the 6th, and that will be on sort of sailing and aging related considerations, but we're also going to sort of talk about any questions that you guys have thrown to Alex Helfand or myself, or put in the evaluations at the end of the PowerPoint. So if you see a QR code pop up, or you've attended any of the other ones, there is a QR code on the last slide for any feedback you have or anything you'd like to see us add to the next series, or questions you'd like addressed in the final presentation. So shout out to that, and we will get rolling here. So seasickness is where we're going to start, because I think there's sort of like two types of people. There's people that say, I don't get seasick, and there's people that have been seasick. And what I will tell you is that no one is immune to seasickness. You can be lucky and not have experienced it yet, but I will tell you anecdotally, the first time I got seasick was about 12 years into being on the water regularly. And I was doing some engine maintenance on the port side of a catamaran during a crossing, and I was overcome by a wild amount of nausea, and it resulted in the usual. But again, that was the first time ever. I'd been on boats. I'd been on big boats, small boats, sailboats, and power boats. Done a couple thousand miles, and never once had a problem. And this was the sort of pinnacle moment for me, where I was like, gosh, I've watched all these people be miserable for so long. This is what this feels like. So we're going to talk about what causes it. We're going to talk about what we can do to prevent it. And then we'll talk about sort of some of the math and stuff behind how it works. It turns out that seasickness and motion sickness are the same thing, and that the sea moves. And so when you get seasick, you're effectively having a problem where your sense organs are in conflict. And I have a friend who once told me you can meditate through seasickness, and you probably can, but for most of us, that's not going to be our ideal option. The only times you don't get seasick are when you're asleep or underwater. And we'll talk about those two options down the road as well. But again, you can have seasickness, as it's called, at sea or on land. You can have seasickness on the dock or standing on the dock itself. And the reason for that is that if what you're seeing and what your body is feeling are different in input, it creates a mismatch in a part of your brain. Um, Now, there's certain things that make you more likely to be seasick and less likely to be seasick, but ultimately, it's when your brain is sensing that you're moving, but your eyes are telling you that you're not, or vice versa. And so, again, standing on a dock watching a bunch of boats move can actually induce seasickness because your eyes are having so much movement input, but your brain isn't feeling that in your ears. So really, this is an ear problem, if you will, more than anything. Uh, I'm going to say this, and it might not be popular, but seasickness is somewhat contagious. And what I mean by that is that there's a lot of sympathetic pukers out there. And the first time somebody gets seasick and has a little bit of vomiting, the odds of somebody else on the boat also feeling seasick almost double. So again, seasickness doesn't come in pairs, but where there is one, there is more likely to be more. So just some nerdy stuff on how this works. Inside your head are two ears and two eyes. And you use your eyes constantly without thinking about it, and all of your visual input is processed in a part of the brain dedicated to visual processing. And this is part of the reason we have such good vision and that we're so capable of using our eyes for navigation, reading, learning, small tasks, all that sort of fine coordination stuff. It's kind of interesting, but if you tip your head all the way to one side or all the way to the other side, your vision stays upright. And that's kind of strange because if you took a camera and you turned a camera sideways, the picture would tilt. But with your head, that doesn't happen. And the reason is that you have two gyroscopes in each of your ears that are constantly telling your brain where your head is in relation to your body and gravity. And so seasickness, vertigo, and motion sickness all are derived from a mismatch between your visual input and your inner ear. And I'll take it a little bit further. If you have a mismatch between your two ears, uh, you can also experience these issues. So everybody's got the ear that they know, the ear lobe part, and this is just a big funnel. It collects the sound and throws it down your ear canal. Your external ear, this is the part of the ear that gets an infection if you don't dry it out after swimming in the ocean. You'll hear people call that otitis externa, which is like a $700 word for outer ear infection. Your middle ear is the pink part on this picture, and that's effectively the drum head that catches the sound waves and vibrates into your inner ear. Your middle ear is what you equalize when you're on an airplane or scuba diving. And when you hear that sort of like popping and stretching sound, that's actually your eustachian tube opening and closing to allow air from your mouth and nose into your middle ear. And so if you have a middle ear infection, you'll have difficulty hearing. Sometimes people can't hear at all. If you've ever had a ruptured tympanic membrane, which can happen from diving or falling into the water or extremely loud noises or blasts, you can end up combining your middle and outer ear. And then you have this really weird looking thing that kind of looks like a snail. And that's your inner ear. And your inner ear is where the magic happens. This is where we interpret sound and voice and music. This is where we take the input of the gyroscope and decide where our head is in space. And this is also where vertigo and seasickness comes from. So when we look at this thing, this is just a 3D printed model of the inside of an ear. And what you'll notice is that there are three little semicircular canals. And in each one of those canals are a bunch of little rocks. And these little rocks float around in a fluid. And when you move, there's a little bit of inertia in the rock compared to the fluid. And so there's a latency in the movement between those things. So effectively, when you tip your head all the way to one side, all the little stones start moving to one side. All the way back, same thing. And these little stones in the movement of the fluid actually is what gives us the ability to know where our head is in space. And it's also what causes our problems with this system. So if the stones get stuck or the stones get put in the wrong part of the ear canal, or we have a input that doesn't make sense to our visual input. For say, I'm looking at a chart on a table, the chart isn't moving at all because my whole frame of reference is moving, but my ears are constantly detecting motion. Eventually my brain's going to freak out. And I say freak out because that's effectively what we feel and call seasickness, is our brain getting stressed that two of its most capable sensation systems are in utter disagreement. And so how does this factor in? Well, on a boat, it could be you're reading a book or reading a chart. In my situation and story from earlier, I was in an engine room. And so I had a hatch above my head, and everything in my field of view was static. Nothing in the front of me was moving, except I was constantly moving back and forth and up and down because of the motion of the boat. And so again, I had two of the angles of that gyro moving up and down and left and right, and my vision was static. And that was enough to make me, while I was in that engine hatch, incredibly nauseous. So my mouth started feeling sweaty, right? When your mouth, all of a sudden you have all this saliva. And I started to feel like a little bit uncomfortable and hot. And when I climbed out of the engine hatch, I felt a little bit better because I had a cool breeze and I could see the horizon, but it was too late. I was going to have to vomit because I had already gotten enough of those stress hormones into my bloodstream that some of that was just what I was dealing with. Things that can cause issues. Again, anytime you're focusing on something that's static. So what do we always tell people? We say, well, get out, look at the horizon. It turns out you want them to see movement. It's sort of counterintuitive, right? If they can see things are moving a little bit, it'll help them. So by having them look at the horizon, they have to see their frame of reference on the boat is also moving. Other things that can happen. If you have inner ear infections, it can cause these canals to swell, and now there's less room for the little rocks and the fluid to move, and they can move abnormally. Smoke and very pungent smells. So this could be the smell of a delicious food to you is nauseating. This could be gasoline, oil, diesel smoke, common cleaners that people use to keep the galley clean. All of these things can be triggering to this system. But remember, your nose and your ears are fundamentally connected. And again, this is a mismatch in what your brain thinks is happening. Just some weird but true facts. Estrogen plays a large role in motion sickness. So women have more estrogen than men, and pregnant women have the most estrogen. So ultimately, women are more likely to become seasick than men, and pregnant women are the most likely to become seasick. Children aged 2 to 12 are at a higher predisposition for seasickness, and people of Chinese descent. And I looked into this because it felt really weird to say, but it's almost in all reference material. And I think that the literature supports that it's not. It's relatively true that all being Chinese or of Chinese descent gives you an increased likelihood of seasickness. Tim, I 100% agree with your point, and we're going to talk about helming and some other mitigation strategies in a minute. But back to the psychogenic aspect of this, nobody gets motion sick when they're driving the car themselves. And helming a boat is very, very similar to that, in that if you have too many other things going on, seasickness is much, much less common. So what do we know? If you've ever had seasickness, you've probably felt some of these things, or seen them on other people. But again, sort of nausea and vomiting are probably the most problematic. Cold sweats are relatively common. This is when you're not hot to the touch, but you're still sweaty. Pallor, you're just looking pale. Headache and drowsiness, fatigue, these are all pretty common as well, with a sort of excessive yawning. And as I described earlier, sort of that weird sensation where all of a sudden your mouth is full of saliva and you sort of are producing it at a rate that feels abnormal to you. These are all going to be relatively common side effects or things that people feel with seasickness. So what can we do? We can prevent it or we can treat it. And we'll talk about sort of the prevention side of this, and then we'll look at some treatment. And then I'd love to hear from you guys about what has worked for you, because I think this is one of those spaces where what works for one might not work for another, and that having multiple strategies, especially if you have folks on board that are new to the boat world, can be quite helpful. So prevention pieces, it turns out that heavy large meals aren't going to be your best friend. I know some people swear by eating a big breakfast and not getting seasick, but you want to eat at least far enough in advance that you've gotten everything past your stomach. And what I mean by that is if I eat about an hour afterwards, the food that I consumed in that meal is likely past my stomach, and therefore it's going to be harder to throw up. When we talk about other foods, again, spicy foods and greasy foods can somewhat increase your likelihood, as can dairy, especially if you're a person who doesn't consume dairy all the time. The number one factor that I seem to see here is that adequate hydration is key. And again, back to the mechanics of this, if it's a fluid in your ear when you're profoundly dehydrated, all of you is profoundly dehydrated. And so you can actually create a little bit of an issue in your ear that way. Know what your issues are. If every time that you read you get seasick, then you're not reading on this passage. Maybe an audiobook is the right way to play it. If strong smells, like if you're going to be defrosting something for dinner and the smell of seafood ever bothers you, it's more likely to bother you when your brain is in this sort of sensory period of assault where there's all these different sensations it's trying to process. Some prescription medications can increase your chance of having seasickness, as can being all the way at the bow or all the way at the stern or all the way to one side if you're on a catamaran. Facing backwards or not facing forwards can create problems for people. And then not having anything to do. And again, I'm not trying to make everybody work, because you got to rest at some point. But if you're doing something and you feel more connected to the motion of the boat and what's happening, the odds of it bothering you are lower. And so whether that's helming or pulling lines or paying attention to your heading, just giving someone a task can actually be a really good way of getting out of or away from feeling seasick. All right. In the treatment world, you can treat seasickness, but it's better to pre-treat seasickness. And what I mean by that is, if you get seasick normally, the next time you go out, we should take something or use a patch or have some ginger if you want to go the sort of less medication way. But you want to do this before you need it. I see a lot of people be like, I started feeling junky, let me put my scopolamine patch on. And that doesn't give the medicine a chance to work. And I think for all of us that are taking people out day sailing, we do ourselves a disservice by not telling people to take these medicines before they come. That way they don't have a bad first experience. They're less likely then to have a bad second experience because of that psychogenic component. There's a couple meds that I'm not talking about today, and it's not because I don't think that they work. It's just because if you go ahead and talk about all of these things, there's 100,000 of them. So we'll start out with the antihistamines. You've got dimenhydrinate, diphenhydramine, and meclizine, or Dramamine, Benadryl, and Bonine. If you're at a store and you can buy the generic version of these things, it's all the same. Benadryl is going to give you the most likelihood of feeling drowsy. Meclizine is probably going to be the most effective of those, and Dramamine is a close second. And you'll hear people toss back and forth that Dramamine works better for them and Meclizine for somebody else. So I think the goal here should be, if you think you're going to have a rough crossing or passage, or you were seasick the day before we drop anchor and start moving here, let's get something on board, and go from there. Scopolamine patches, or hyoscine, depending upon where in the world you are, can work for up to 3 days. These things are profoundly functional, and what I will tell you is that they are not inexpensive ever, but they are always more expensive when you're near a dock. So I strongly recommend getting a good amount of these if you're going to have folks on the boat. And even if you're not, it's worth having a box or two, because they're not going to be cheaper once you leave sort of the terrestrial life. A couple things: you put it on, you take it off after 3 days. You can put it on and take it off in less than 3 days if you'd like to, but the next one needs to go on the opposite side. So you should be taking one off, cleaning the skin off, throwing it away. And then if you need to put on another one, it should be going on the other side. And we'll talk about why that is in a minute when we start talking about side effects. Ginger. I didn't put in a slide here about all of the naturopathic remedies, but ginger is one that's being used in some pharmaceuticals, and that I think is worth noting. It's inexpensive and readily available in a lot of places. You can buy fresh ginger and chop it and freeze it. It'll keep for years. You can have sort of any method possible to consume it, but I think fresh ginger gives you sort of the best chance of nipping it in the bud here. And again, people do it as a chew. Ginger ale that has enough ginger and it can help. Tea can help. I like to have people just chew on a little bit of ginger and some honey. That seems to do well for people because it sort of mutes the taste a little bit. I think honorable mentions: the acupressure and wristbands. They work for some people and not at all for others. And I don't want to say that there's a placebo to it, but if you want it to work, its odds of working are higher. So again, if you've got that friend who doesn't want to come out on the sailboat, and every time they come out they get seasick, they might just want to get seasick. And it sounds counterintuitive, but you can will a lot of things into existence, and seasickness, again, or motion sickness overall, can be one of those. For people that are nervous or scared, it's more likely to happen to them than it is the person who's calm and comfortable. Again, I got one question or one statement. Scopolamine can work on people that are seasick already. I'm not saying you shouldn't use it if someone's already feeling queasy, but I will say the odds of it working are higher if it predates the sensation of nausea and other seasickness symptoms. But again, I don't work for any of these companies. I don't care what medicine you choose to get. I think generics are totally fine. I think every boat, ocean going or day cruiser, needs to have at least one of the pills, and preferably the pills and the patches. Okay, so this slide and the next slide I put in here so that if you ever download this presentation or take it with you, you've got a representation of the medical aspect here. But with all of the medicines on the last page, with the exception of ginger, if you take too much of them, you can end up with some side effects. And there are common side effects that aren't that big a deal. Dry mouth is a big one of those. Disorientation. Remember that this person was already slightly disoriented and feeling queasy, so we expect this is just an exacerbation or something getting worse they already had. And then we've got drowsiness. If anyone's ever taken a Benadryl, it does one of two things to people. It makes you really sleepy, or it makes you wired. And so it's just worth considering that this is, some of these are common side effects of medicines that people take for other reasons. And again, dizziness, sweating, and a sore throat are relatively common with all of the medications we talked about. Sore throat and sweating more often going to be true with scopolamine. When we talk about dangerous side effects, anyone who's confused or isn't interpreting things right, they think there's, someone's talking to them when they're not, or they think that you're going the wrong way. Sort of feelings of fear that seem unfounded should be worth putting there. Enlarged pupils, this is common on the affected side. So if I put a scopolamine patch on, I want to wash my hands and not touch my face. It turns out that getting scopolamine on your eyes can actually dilate your pupils really big and let in too much light, which is also why people sometimes describe having light halos, so a little ring around a source of light, or even an inability to look at or near a light fixture because it's uncomfortable. That's photophobia. And then on the real bad side of things, and very rarely, and usually only when somebody's taken a pretty absurd amount of these medications, you can have seizures or a loss of consciousness or a loss of memory. Again, this is super infrequent, but I didn't want to give you an incomplete picture. And so that is why I've got this list up here. Remember that when we're dealing with seasickness and we can't get off the boat, we're going to have to acclimatize to it and get used to it. And so aggressively medicating and then running out of medicine is something we see a lot of folks do. So just remember, having extras of this on board for yourself and for anybody else that you're caring for can be super helpful. Okay, so this next slide you can ignore entirely. I just put it in here because this is sort of a breakdown of how you get these medicines, what they are, what format they're in, the usual dose, and how long they last. Again, a scopolamine patch is by far the longest acting of these agents. Most of them have like a 12 or a 24-hour max, whereas a scopolamine patch can give you days. I will also say, just food for thought, and you don't have to take this for anything more than my opinion, but you can't puke up a scopolamine patch. And so one of the considerations for the person who's already nauseous is if I give them a pill and they swallow it, and then they immediately vomit, did they get any of the medicine? And then can I give them more? Because if they did get the medicine, I don't want to cause an overdose or any sort of untoward effects. But at the same time, I don't know if they absorbed it because they just threw up. So again, for me, I really like things that come in an ODT or an orally dissolving tablet, or things that are given another route. Okay. So what else can we do to get rid of seasickness? We can go swimming or get in the water. We can drive. We can get outside and get some fresh air. We can use our better living through pharmacology and try and blunt the response from the body. And then again, we can avoid our triggers. Try and be adequately hydrated, try and be adequately slept. These are all going to be things that help us to hopefully stay away from seasickness. Any questions about that before we keep going?
Quick question. In the Caribbean and Europe, people talk about using sturgeon, but I don't think that's available in the States. Any reason?
Is it sturgeon like the fish?
I'm not sure if it's sturgeon or I think it's spelled Sturgeon.
Alex?
Yeah,
It's Stugeron, and
Stugeron.
it's also legal in Canada.
Okay.
Let me look up what we're talking about real quick so that I know. It's not something I've spent a lot of time with, but let's. So Stugeron is the brand name, right? And then
Actually, I don't know.
it sounds
Neither
like
do I.
it. I will look that up and get back to you. I will say that, and maybe this is the most political way to say it. The FDA has a lot of interesting rules for medications. So much so that like there's a lung cancer vaccine that we're still not allowed to use in the United States because it was made in Cuba. So there is a very possible chance that this is a wonderful medication and that I'm unfamiliar with it because we don't use it here often. But I will do a little bit of research and talk to my docs and bring this back up at our next talk because I think it warrants digging into a little bit and not just me looking at it on my phone real quick here. Thank you, Alex. I will look into that and get back to you guys. Anybody else? Questions, comments, concerns about seasickness, things to share with the group? Questions for me? I was told that although getting in the water can clear your seasickness out pretty quick, it's inappropriate to do so on a crossing. So don't just jump off in the middle of the ocean to get rid of your seasickness. All right. So let's get to the gut of the matter here and talk about GI distress on board. So the first part of this, I just want to talk real quick about RO or reverse osmosis water. A while ago, this was like not super common and not a lot of people had them on board their boats. Now, an RO machine or a reverse osmosis water maker or a desalinator, they've all got 100 names, is pretty ubiquitous on long distance cruising boats because it allows us to extend our range considerably and it allows us to turn the plentiful salt water into potable drinking water. With that being said, it's potable, but RO water is actually not without conflict or problem. And that's because the water is so pure that it actually has less minerals in it than your body does. And as a result, when you drink reverse osmosis water, you can actually leach some of the nutrients and minerals out of your body and into the water to be sort of digested. So that can be a problem for us because normal water has a total dissolved solid count that's not super high, but RO water, it's too low, and that can actually create some fluid shifting that's a problem. If you've ever gone from your house where you have soft tap water or well water or something like that, and then you get on a boat, you very well might have some GI distress from the change in electrolytes. And we'll talk about that in a minute here as well. But do understand that the idea with RO water is you're getting pure water out of a machine. And unfortunately, some of the things we did to purify that water create a chemical problem that, while safe to drink in small amounts, may actually create some other problems in large quantities. We're going to talk about emergencies versus inconvenience. We'll talk about diarrhea and vomiting. We'll talk about how to do an abdominal exam so that if you call a service like ours, you can give us the most sort of accurate information. We'll talk about how we section the abdomen off, and also about what to do if we think somebody might have something infectious on board and we have to share a toilet. So again, the game plan here is that the salt water comes in, goes through some sort of pre-treatment filter, and that's designed to keep the membranes clear. And then, you know, some of your boats might have 2 or 3 of these pre-filters, depending upon which water maker you're using. From there, we're going to actually conduct the reverse osmosis or purify the water. And then afterwards, in the perfect world, you're going to go back and add the total dissolved solids that you took out. So the advantage of RO is we can desalinate water and it's pure when it comes out. We use that a lot in medicine. The disadvantage is that all of the minerals and electrolytes in that water went away. And so you can actually see increased breakdown of teeth. You can end up seeing people with loose stools and other sort of electrolyte related problems. But again, RO water by itself does not hydrate you. You actually need to ensure adequate electrolytes are present in the water. Remineralizers have become pretty popular. They work pretty well, but do understand that you want to monitor these things, make sure that they're not putting too much in the water or not enough in the water, because then you're not fixing your problem or you're creating a new one. Can also be corrosive to pipes, plumbing, things like that. So again, RO extends our ability to be out for long periods of time. But if all you're drinking is boat water out of an RO machine, you probably want to consider remineralization or an electrolyte tablet or something like that to help make that work better. All right. Okay, I'm going to use the same picture a few times. These are all on the right in white lettering. These are all medical emergencies, no matter where you are. If you're on a boat 300 miles from the nearest shoreline and that place has a clinic that's only open on Tuesdays and Fridays, then we want to be a little bit more cautious because we don't want to end up getting caught unprepared. I think most people have heard of appendicitis, but this is just an acute infection of your appendix, which lives down in your lower right quadrant. So I want you to imagine that you're looking at a person who is laying down, and you're going to take one line and put it across their belly button that divides them into a top and a bottom half. You're then going to take that same line, rotate it 90 degrees, and split their abdomen in right and left. Now remember, this is one of those things that people in healthcare take for granted, but I don't care if it's your right hand. I care if it's their left hand. So just remember when you're looking at a person that even though it's on the left when you look at them, it is still their right or the patient's right. So we'll talk about appendicitis and GI bleeding, a little bit about hernias, hepatitis, and then we'll talk about trauma, obstruction, urinary retention, and ectopic pregnancies. So what type of liquids? Yeah, so you can do this the inexpensive way or the very fancy way, and they all work so long as you do your math right if you're making it yourself. If I'm going to go on a long trip, I'll probably make like a gallon of ORS or oral rehydration solution in powdered form. And this is effectively what Liquid IV is selling, or Noon. Again, I don't work for any of these companies, but Liquid IV is pretty expensive, but very good. Comes in another flavors. Another good one is this company, Noon. I like these because they actually come in like a tablet form, but they also come with a desiccant so that they stay dry while you're not using them. Again, form factor for me, this little thing here is more convenient, but I do like them both. So do liquids in the stomach have an effect? Sure, they do. So again, anything sloshing around inside your body is going to give your body a weird sensation and could potentially create a problem for you. I think having something in your stomach can make it less irritable as well. So again, I think the idea of eating right beforehand is not great, but it shouldn't necessarily hurt so long as you're not doing some sort of adventurous dining. We'll talk about trauma, obstruction, urinary retention, and ectopic pregnancy here as well. So appendicitis, very common. The only people immune to appendicitis are people that have had their appendix out. On the medical screening form that I like to ask people about before I go on a cruise, one of the questions I ask is, do you have all your organs? It sounds weird, but if you're missing your spleen and your appendix, those are two dangerous organs that can't be your problem. Again, you can have other problems, but again, having no appendix means that your right lower quadrant abdominal pain. So again, that's belly button down and to the right on your side. That's your right lower quadrant. And the appendicitis pain tends to start right around the belly button and gradually move down into the right. And if you call us or another service and you say, I've got pain that started in the middle of my belly and moved down to the right near my hip bone, that's appendicitis all day. We know, okay? Fever can be a problem here because of an infection. And again, most of these are going to require a surgical fixation. So that unfortunately means we need to get off the boat and to a place that's capable of doing that. All right. All right, GI bleeds. So this is when you're bleeding into some part of your GI tract. So if you bleed into your mouth and you swallow it, it goes down into your esophagus and then gets digested. Because it's digested by that acid, it denatures the blood a little bit, which is what gives this sort of characteristic coffee brown black color to vomiting. Now, you can lose blood from your GI tract in two ways, out the top and out the bottom, or both. I think that the only advantage that I can say is losing blood out the top. You can control it a little bit more than out the bottom. The chart on the right is just for your illustrative purposes, sort of what we're looking for and what we think. So those sort of black things you see at the top, that's completely digested blood that sat in a stomach for long enough to sort of denature all the proteins. You can fit your whole blood volume in your GI tract. So again, if somebody's bleeding into their stomach or bleeding into their intestines, they'll fill it up and they'll be out of blood. Good news with GI bleeds, though, the most common cause is actually when somebody has hemorrhoids. And it frequently results in a person having like blood on a tissue. I think the good news is when we see that, we can usually fix that by either using some hemorrhoidal wipes or by trying to avoid straining on the toilet. I know that boat heads are not always the most comfortable, but that's worth just considering. Other than that, anytime you have bright red blood coming out the rectum, you're worried about a lower GI bleed. Anytime it's black and tarry or looks like coffee grounds, it's probably on the top side. Again, when we talk about GI bleeds, be more considerate of this in folks that have blood thinners or take a daily aspirin. as well as sort of any time that somebody reported weird stools. But again, the number of times that we get called to a house and we find out it's someone has hemorrhoids and they got some blood on the tissue and that's it, that's typically not a problem. Okay. Next slide here. All right, so hernias. Some of you may have one of these and they're not usually a problem. I don't want to freak anybody out, but a hernia is where a piece of your tissue has sort of come out through the muscular or cavity wall. Again, down in the right-hand corner, you'll see there's a number of things like an epigastric hernia or an inguinal hernia. And these are all hernias that can cause discomfort, maybe some pain. Maybe they can get in the way of things flowing through the canal of that organ, but they can also become strangulated. And the way I would describe strangulation in the hernia sense is like you watch a clown make a balloon animal, and when he twists the balloon and lets go and nothing happens, that little piece of balloon stays right where you put it. The same thing can happen to a hernia. So again, these are not life-threatening by themselves, but if they become strangulated, they can die. And if a part of your abdominal sort of functions dies, you might have an infection from that or another set of problems. So again, if you've noticed one on yourself, I recommend strongly having that checked out by your primary doctor before you go on your next cruise. Again, you might walk in and they might say, you're totally fine. Don't worry about it. Okay. Good. All right, so the hepatitis. This is another sort of potential problem in especially some parts of the world, and it is dangerous because some of it's treated, some of it's not. There are like 7 or 8 types of hepatitis, but realistically, we're going to talk about them like there are 6. So you have Hep A and you have Hep B. These are the 2 that everybody is vaccinated for if they got all their shots. Hep C is notably more difficult to acquire, but we can also typically not get rid of it. It's frequently caused by blood-to-blood contact, but it could be body fluid to body fluid. Type D is actually type C for a person who has hepatitis B. So once you get hepatitis B, the only thing we can do is try and make it not come back. And if you were to become infected with hepatitis C, we would call it hepatitis D. And then again, hepatitis A and E are pretty similar. Unfortunately, there's no vaccine for hepatitis E. When we talk about other causes of hepatitis, though, we're going to get the same symptoms. And in that top picture there, you see somebody with icteric sclera or a yellowing of the eye and skin, frequently called jaundice. And if you see that, it's liver problems. And if you see that in a person that didn't have it the day before, that's an acute problem with their liver. And that could be a ruptured bile duct, that could be some sort of cirrhotic disease. So there's a lot of things that could cause it. But again, the one we see the most is folks with alcoholic hepatitis, where they drank so much alcohol or took so much Tylenol that their liver is struggling to keep up. And what they're feeling is their angry liver, if you will. Okay, this is a blown up version of the picture that I've been using, and I put it up here because I think this is worth having a picture of somewhere or being able to pull it up. And that's because it's got an outline of where your different organs are. And we're going to talk about some of those right now. So if you think about where your organs lie, your right upper quadrant and left upper quadrant, so below the rib cage but above the belly button, this is going to be where you have your liver and your spleen, your stomach and your gallbladder, and some of your colon. When you talk about the lower quadrants of your abdomen, you're looking below the belly button and sort of above your pelvis. And then when you talk about the pelvis or sort of your hips, this is where you have your pubic region. And these are sort of going to be helpful for us when we're talking to you about where the pain is. Trauma really in trauma, you need to be the most worried about the solid vascular organs like your liver and spleen, pancreas, and like those are sort of the big three there. When we look at epigastric damage, this is sort of where your stereotypical my belly hurts, people sort of rub their hand there. And then again, lower right quadrant we said was appendix. I haven't talked a lot about ectopic pregnancies or pregnancies today, but please understand that the entire organ system we're talking about, both men and women have. And if a woman had right lower quadrant pain or almost pain radiating to their back, we would consider whether or not that was potentially an ectopic problem. I got to step on it here. So this is up here for you, but urinary retention would cause rigidity and swelling in the pubic region where the bladder is. Obstruction, if there's a kink in the pipe, you could see sort of a backup of fluid or a backup of solids all the way from that obstruction upward. And then again, trauma, if someone gets hit in the abdomen, these organs are soft and unprotected. And so we've got to be careful there. This is how we recommend palpating an abdomen. This is just the quadrants as delineated by the belly button. And we want to have the patient lie down so their belly is soft and supple. And then we're going to sort of apply gentle pressure so that we can try and feel and feel for rigidity or guarding. Guarding is when you go to push on somebody's belly and they tense up real quick because they think it's going to hurt. Both guarding and tenderness should be resulted as a positive on these exams. You want to start where they're not hurting, and you're going to push down slowly in sort of a rocking motion, and then you're going to let up slowly in a similar fashion. Again, because it's helpful to know if they had pain on the way down and the way up, or just pain on the way down, or just pain on the way up. All right. Remember, we want to look at the person while we're doing this because they might not want to tell me they're in pain, but they might make a face that'll help me see it. Good old diarrhea. Everybody loves it. It's everyone's favorite day on a boat, especially. The thing to keep in mind with diarrhea is that it's safe to stop if you don't have an infection. If you have an infection, sometimes you want to let all the nasty critters out first. And so if you think you have foodborne illness, you do not want to stop your diarrhea. You want to get it all out of you. Clues for foodborne illness would be you ate something and in the next hour or so, you ended up losing that thing. Other people who ate the same thing are having the same problem that you are. Those are times where, unfortunately, we're going to just want you to let at least the majority of it out before we actually consider stopping it with something like a loperamide or an Imodium. Remember what I said about RO water? People joke about Montezuma's Revenge or from drinking water in countries that it's less clean. It's actually almost never a microorganism. It's almost always a change in the electrolyte concentration. If you've ever had to get a colonoscopy, they give you this stuff called bowel prep, and it's a electrolyte heavy fluid. And what it causes is a lot of water to be mixed in with your poop so that you go poop and you flush out your whole bowel. Well, RO water can functionally do the same thing. There's so few minerals in it that it actually pulls minerals out into itself. And then that can cause a cascade of fluid to come try and help out as well. You also see people get constipated because of RO water. These pills are really good at stopping up diarrhea. The problem is that if you stop them up too much, now we're constipated, and that's going to create obstruction and more problems. But again, imperative medicine to have on board, loperamide, hydrochloride, 100% worth having. And then good old vomiting. So again, when we look at vomiting, Zofran is another one of those medicines. This one's a prescription med that you can get from your primary care doctor or through a service like Duration Health or one of the other companies out there that does this. It's not very expensive. It comes as an ODT and a pill. In my opinion, there's no point in getting a pill for vomiting because if you throw it up, it's not going to help you. But the ODTs are orally dissolving tablets, work wonders. You just put it in your mouth, a couple seconds later, it's gone, all the medicine's in. And now if you vomit, you didn't swallow it, it's not in your stomach, it can't come out, and it's still going to continue to work for you. It comes in 4 and 8 milligram doses. To be honest, I just carry more 4s, and that way, if I don't need extra, I can save it for later. Remember those same rules with diarrhea. If I think that you drank something you shouldn't have, ate something you shouldn't have, I want to let your body purge itself of the problem, and then I can consider getting rid of the nausea. If someone's vomiting without nausea, I'm going to also let that go for a minute and make sure that we aren't trying to rid ourselves of something bad. We see this happen with alcohol that's poorly made, as well as too much alcohol, regardless of quality, as well as foodborne pathogens, and then sometimes chemicals. If you're really dehydrated and you drink some really cold water, you can end up with sort of an instantaneous reaction to that temperature change as well. Avoid cold fluids. We want to go with like tepid room temperature water, and we want to take small, tiny sips. If you're struggling with that, you can also chew on ice chips. Again, for anybody on the call who's dealt with morning sickness or anything like that, vomiting can be extremely uncomfortable. It can also be a sign that somebody could be pregnant. So again, if someone's got weird nausea and like lower left quadrant pain, and they don't have a fever, I might start, saying, oh, well, they've got nausea and they've got pain. Those two things are symptoms of one that could be the answer there. So just again, worth sort of putting all your symptoms together and creating a collage of what's going on so we can try and have the best option. Got like a minute left. Again, hernias, any of the things that you've noticed about yourself that you can get checked out beforehand. I think dental visits are a huge one of these. Anything we can do to understand what we've got going on at baseline before we get out on the water, the more likely we are to be able to enjoy the water without having to see anybody in a hospital or a clinic. And then also beyond that, making sure we have the appropriate medicines to treat things on board like diarrhea or like vomiting, having an antibiotic to deal with an infection. All those things are going to be huge for us. Taking some time to do some learning. I think, again, the more you know about these things, the less scary they can be. And other than that, I thank you guys for your time, and we'll see you on the next go round.
Okay, so thank you, Alex. It's been really enlightening once again. So we have there's 2 questions that were popped up. One from me. So what happens if you eat a bunch of mealworms that were hiding in your cereal?
They should be fine. It's extra protein.
Yeah, that's what I thought. Okay.
Yeah, I mean, people eat bugs all the time, and if the bugs were eating your cereal, then effectively you didn't eat a bug that ate something bad.
That's I guess one way to look at it. They had good taste.
Yeah.
All right. And second question from Matt. If you have a crew member that has celiac disease on board, what issues do you need to be aware of, and how do you maybe manage things aboard so that they don't have a problem?
Yeah, so I think anytime that you're going, it's a fantastic question, Matt. I think anytime that you're going sailing and you have people with known medical ailments, it's worth having a conversation with that person and saying, when was the last time that you had an issue with this? What was done to resolve it? Right. So if somebody has celiac disease and they haven't had a problem in the last 2 years, let's say they haven't had a flare up, then we're probably okay. Celiacs, obviously, we're going to avoid gluten. We're going to probably bring more loperamide than we would otherwise. I like, if I was going down to the Caribbean, I would bring a lot of gluten-free mixes because you can't find that stuff in many other places. But again, like some Beano for the gassiness, some Miralax for the potential constipation, some loperamide. I would basically just take every symptom of celiac that I know that they've experienced and try and come up with a way to avoid it. Again, there are many symptoms to celiac outside of diarrhea, but I think on a boat that can be one of the more problematic ones. I would also make sure if the person, especially if the person was a female that I had, you know, either iron supplements or a way to make sure that their iron levels stayed high, as well as a good source of calcium. But I think for the most part, a good diet and good sort of supportive vitamins and minerals are going to be helpful there. And then going out to eat is obviously a huge joy of cruising, but I've never really trusted 100% of the things that I read when it's like, oh, we have gluten-free pizza, and it's like, what's the difference? And they're like, we make the dough today, and you're like, okay, like gluten does come from sitting out dough, but it also, it's present, and so people, I guess, now that gluten-free is a diet that a lot of people are on for reasons other than celiac, I found that there's some folks that don't quite understand the medical necessity to a person that truly has celiac disease.
Okay. One final call for any more questions? Doesn't look like it. So again, thanks very much, and looking forward to our final webinar in May. And with that, I'll stop the recording and say goodnight.
Perfect. Thanks, guys.